फक्त फोन बरोबर होत. जर लॅपटॉप असेल तर लॅपटॉपला स्वतःहून करते. तर खूप लागतं राखी बोल किती आहे ना हा ठेव. रिकॉर्डिंग रेकॉर्डिंगसाठी आणि ते ऍड करायचं तिला माहिती आहे त्याचा ब्लॉग मध्ये प्लेन आउट बरोबर जर सगळ्यांना बोलायचं मी करायला
राखी अनम्यूट झाली ना इथं आउटपुट दिसलं. समजलं मी मोठा केला तर मोठा दिसणार तुम्हाला. समजलं कोणाला घेऊन नका करूया लक्षात बोलू शकतो गॅलरी नका करून आणि काय
States of fluid pattern, I think.
एक बार लाइट बीट जरा देख लेगा अनर भी फुल रखो ना रन चालू नहीं Going live. Hello all. Nice to see you in this new year. Am I audible to all? Can you just put up a thumbs up or a reaction in the chat box if I'm audible to all? Doctors, please let me know if I'm audible. Great, great. Thank you, thank you. I see a lot of familiar faces and a lot of new doctors joining our community. So let me welcome once again all of you to our amazing inner circle session and the first for the year 2024. So just all those who are joining in for the first time, can you just identify yourself? Just put your name and your location please in the chat box, so all of us can welcome you in the community. Yes, Dr. Manu, Dr. Saurabh, Dr. Sneha, Dr. Sumit, great to see you around. Just those of you who are joining for the first time, please acknowledge Dr. Sneha from Ulhasnagar. We welcome you, Dr. Rohit from Punjab, Dr. Shalu Jain from Ghaziabad. Welcome, madam. So I see a lot of action takers in the implementation here. So all those who have been a part of the community, we had some resolutions together as a community in 2023, and we have already starting to implement it. And we also welcome Dr. Lalit Kumar from Jalgaon, Dr. Jyoti from Raichur, Dr. Abhishek from Bihar, Dr. Sri Harsha, Dr. Jerin Kochi from Kerala. Amazing, amazing. Dr. Ashul Trivedi from Subharti Dental College, Meerut. So nice to interact with you all. Dr. Rohit Agrawal from Ranchi. So I'm sure all doctors who are joining for the first time, you will have a wonderful time in this community. So your journey has just begun in this amazing community. And as more people join in, so any doctors who are joining the inner circle session for the first time, I request once again to acknowledge yourself. Just let me know your name and your location. Dr. Nitin Kapoor from Delhi, welcome. Great. So nice to see all of you. Dr. Anil from Kerala. Dr. Rohit Agrawal, welcome for the first time. Dr. Kaushal Singh from Mathura. Dr. Roma Goswami from Meerut. Dr. Samir from Raichur. Great to see you. Now, all those who are already in, quickly, I just want all of you, some homework was given to all of you to watch 4 videos before attending this session. So those of you who are probably not seen the videos yet, I'm going to repost. Savita, just put the link for all the 4 videos again. So I'm just going to repost the 4 links, which all of you should see probably now after this session, so that now you can correlate and connect the dots. But those of you who are already in the community since a while, Have you watched the videos? Just type yes if you watched the videos. And for some reason, if you haven't watched them, type no. Dr. B.K. Arora from Punjab. Sneha, good, you watched it. Dr. Rupesh, Dr. Sumit, Dr. Kaushal, Abhishek, Dr. Samir, great. So almost all of you have done your homework, and I'm sure those who have done the homework will really enjoy this session even more. We'll just wait for a minute more before we start. Dr. Johnny, Dr. Hanuman, Dr. Faisal, Dr. Prashant, Himanshu Pandey hasn't seen it. Please watch it once you. The link has been reposted by me, by my team. So just watch these 4 videos. It's like compulsory you watch these 4 videos to get the deeper knowledge about the system. Okay. Kamaljeet Singh, thank you. Dr. Anurag, Dr. Lakshay, Dr. Joni, Dr. Sujay from Bangalore. Welcome to the gang. Dr. Ankur, yes, you have watched it. That's great. Great. Right. So amazing. So I think almost all of you have done the homework, and I'm sure that will benefit all of you today. For those who are not able to join the Zoom, we are providing one more Facebook link because I think some doctors have messaged us that they are having some problem in connecting via Zoom. So we have sent the Facebook live link also. So those who are having some difficulty or getting disconnected from Zoom, you can watch this session also now via Facebook. Great. So before I start, I want to quickly revise a few things in less than 5 to 6 minutes, maybe 8 minutes maximum, so that all of us are in sync and we get the maximum out of it. So let me just share my white screen. So when it comes to the spill protocol, which we term it as S.P. Is my white screen visible to all? Yeah. Okay. So when we talk about the spill protocol, which means simplified protocols in immediate loading, S.P.il. Okay. The R-line series system is encompassing all of this, so that for any case and every case we have divided the system into 2 basic parts. So to keep it very simple, you have the basal implants or the 1-piece implants, and we have the 2-piece implants, or what we normally call as the conventional implants. Now the benefit of this is that irrespective of which system you want to follow, with the same protocol, same thought process, you can use these spill protocols to place the implants, and in 90% of cases that will be flapless, graftless immediate loading, which we call as the simplified protocols in immediate loading. Now, last year, that is 2023, we focused a lot on the basal implant part, but today we are going to, so this part we focused a lot. So all those who were a part of the community understood the 3 components of this part as well, which primarily included BCS implant, KOS implant, and KOS and BCS MU. So with this, you were able to make cement retained as well as screw retained implant prosthesis on your single piece implants. Now today we are going to discuss with all of you the conventional implant series, which is primarily divided into 2 components: the hex, which is compatible with all your Israeli systems like Norris, Bioline, Edin, etc., and the conical system, which is a conical connection between your implant fixture and abutment, which is compatible with your ostium, dentium, etc. For the sake of simplicity, today we are going to focus on the hex system, which is more recommended for immediate loading. The reason being, if you try to put excess of torque in any conical system, there will be flowering of the implant. So if you ask me, the conical hex, which is a combination of the conical connection in a hex, is the best system which is available as conventional two-piece implants in our line, which is further categorized into DSI and CIH. Now, just to test you all out, do all of you know the full form of both the implants? This for the new one I'm putting up, dental spiral implant is the DSI implant, and the CIH implant is the compressive, not conical, it's the compressive internal hex. This is the entire armamentarium you need to cover up all types of cases in flapless immediate protocols or in rare situation delayed loading protocols. With this system, you will be able to also adopt delayed loading. 90% of the cases will be immediate loading, and if you wish to, manual or digital protocol. Is this clear to all? Just please type clear in the comment box. If you want, you can even take a screenshot. So everything is clear. This is the entire framework of the system. Please type clear in the comment box so I can move ahead further. Great. Perfect. Now, when it comes to the DSI and CH system, which I am discussing today, let me just quickly show you before I hand over to our professor, Dr. Sumit Agrawal, sir, who has been kind enough to share his knowledge today with us. Sir, with your permission, I will just take another 2 to 3 minutes especially for the newcomers, so that they are also well oriented before we hand over to you. So just get a mic over here, please. Just get a camera over here. Please get the quickly get the basal also, BCS, QS, QSMU. Is the screen visible to all? I'll just stop my video and you can make. Is this screen visible to all where I'm keeping my hand? Is it visible to all? Just type yes in the comment box if the screen is visible to all. Great. So for the newcomers, just give me a paper and pen, please, quickly. Thank you. So for the newcomers, just one more time, very, very quickly, the SPIL, SPIL protocol, simplified protocol in immediate loading, which means with the one thought process, similar protocols, we will be placing both basal as well as conventional. When it comes to basal, we have the smooth surface implant, which is called the BCS, the rough surface implant, which is called as the QS. So this, please give me BCS and QS. And you have, so these are this category of implant. Yeah. So this is the BCS implant over here. So this is the BCS implant over here. Okay, this one BCS, and this is the compressive or QS implant. So this is the BCS implant and this is the QS implant. Clear so far? Is it clear to all of you? Please type clear. We also have the screw retained basal implant with both BCS and QS, which has the screw retained option, but they are single piece. Now, why they are called single piece? Because the implant fixture and the abutment, everything is one piece. That is the reason they are called single piece implants. Clear so far? Next category of implants, in the conventional, we have the internal hex, which means that the connection inside over here will be a hexagonal connection in the implant fixture and the abutment and a conical connection. The hex system will be compatible to all your Israel systems, and the conical will be compatible to your Korean systems, Ostem and Dentium. And this is compatible to Edin and Norris and Bioline. In this system, we have again the two systems, the DSI and the CIH. Okay, this is called as the dental spiral implant, and this is called as the compressive internal hex. So far to all of you. Now, when it comes to the DSI and the CIH implants, if you see here, you can clearly see that the DSI implant is a blunt implant, and this is having a sharp taper. Whenever you want to use the DSI implant, which is the blunt implant, you can use for delayed loading, sinus lifts, any cases where you still want to do bone graft for reasons best known to you, you can use it. Or in cases where you're going to restore one side first, wait for some time and then load the other side. So restore unilaterally in delayed load protocols. Wherever you want to engage or perforate the opposing cortical, your implant of choice will be CIH. Just put a photo of this also, please. Is this clear to all? Can I get a clear from all of you, please? Is this clear to all? Great. Now, why do we need this kind of elaborate system? Is to cover up every case and any case. Then now some of you will say, but then already so many available market systems are there. What is unique? The unique part is that once you are able to get the complete knowledge about the system with 1 or 2 drills, maximum 2 or 3 drills in the max situation, you are able to place any of this implant, number one. Second is all the connections, interconnections are similar, which means whether you put a CIH or a DSI implant or you put a KOS MU implant, once you place them, the connection, the platform becomes same, which means you can mix and match them. The third important thing is the cost factors, which we'll discuss later on. But just to keep you for the newcomers in the loop, the basal implants will cost you anywhere around 2,500 rupees. And even the two-piece implants, the conventional implant also cost you, the implant part cost you 2,500 rupees. Implant with the multi-unit, which is a two-piece implant with the multi-unit, will land anywhere around 4,000 to 4,500 rupees, depending upon the scheme you get. So you can see the value exchange also happening apart from the uniformity in the system. Also, to add on, from my 14 years of progressive experience in implantology, where initially I used to do a lot of conventional implants, all of you know that I was also in the basal IF foundation teacher. Then I did a lot of basal implants. So combining my knowledge of speaking for Edin implants, doing lots of conventional implants, and then also doing lots of basal implants, integrating all the pros and cons of all this system, this entire system has been devised to give you all the maximum advantage. Along with that, we couple it up with such kind of programs so that there is crystal clear clarity on the implication. So I hope all of you find this a value add. Now, before we give it to Dr. Sumit, just quickly, again, I will show you the kit also. and I will admit Dr. and I will then request Dr. Sumit sir to take over. So just give me a minute more. And all of you are able to see the video screen again. So those of you who are struggling to join, please share the Facebook link. So those of you who are struggling to join in the Zoom, you can just join on the Facebook also. Please share the Facebook link. Okay. So you see here this simplified kit. I'm not going to go in much of details because already we have put up 4 videos which you should go in detail. But let me right now show you the kit very quickly. So you can see the drills as mentioned. More importantly, the fixture driver, which is there for holding the implant. Okay. So yesterday we had put up one question, the technique of holding the implant. So one is with the fixture driver. The second is if you want to use a micromotor. So this will go in your micromotor and you can use your micromotor also to place the implant. So you can use the micromotor. So this will be your spinning in your micromotor. So you can attach it to your micromotor and this is a micromotor connection. The third way of using it is this special interlock driver. Once you lock it, you will see your implant will never fall off. Okay. And the next and the last way of placing the implant, okay, is this T driver, which is with the hand. So this one system allows you to place both the implants with the same driver, same components, and depending upon the site, use the very different types of implant. So now I hope that all of you are clear absolutely about the foundation of how the R-line implants. I hope all of you are now clear about the foundation of R-line implants, the thought process which has gone into it, and how the system is going to help you out in doing almost all kinds of cases. With this, I welcome our sir, Dr. Sumit sir. Sir, thank you for joining us, sir. And before I give over the presentation to him, sir is going to discuss with us the techniques for tilted implantology. Let me give you a brief about Dr. Sumit Agrawal, sir, for those of you who still don't know much about him. Am I audible to you all? Am I audible to all? Am I audible to all? Yeah. So those of you who are not aware about Dr. Sumit Agrawal, sir, who is going to discuss today about the tilted implantology with CIH and DSI implants, let me give you, he's done a lot of things, but to save time, I will just put up a few important points. So Dr. Sumit Agrawal, sir, has completed BDS in 2005 from prestigious Government Dental College, Rohtak, Haryana. And through all his entrance exam, he was a topper. MDS in prosthodontics and implantology from KLEB Institute, Belgaum. He's extensively trained in advanced implantology and certified basal implantology from International Foundation, Germany. He has also worked as a senior resident in Government Dental College. He worked post MDS for 14 years with experience of over 4,000 implants. He is a visiting consultant across Delhi and NCR region, awarded with research grant to do clinical research in basal implantology by Subharti University. He is a guest at International Conference World Dental Conference in Malaysia 2009, where his lectures were, his lectures were liked by all. He has around 40 publications in his name, including publications and authored 4 books in dentistry by Lambert Academic Publishing UK. Congratulations, sir. Big achievement. Let us just applaud Dr. Sumit sir for such a wonderful achievement.
Thank you, sir.
And he also holds fellowship of forensic odontology from Council of Accredited Forensic Odontology, approved by Government of India. So with this amazing brief about sir, I think all of you can understand the kind of knowledge he must be sharing. Let us all type welcome for Dr. Sumit sir. Sir, the podium is all, I think the virtual podium is all yours, sir.
Thank you, sir. Sir, thank you for your kind words. Thank you, Rohan Virani, sir. And I'm very thankful to Trisa Enterprises and you, sir, particularly for inviting me for this guest lecture. This presentation, I'm just going to share the screen now. So I hope everybody can now see the screen. Is my screen visible to all? Is it? Please type yes if it is visible to everyone. Okay. Yeah. So very good afternoon to one and all the busy practitioners and all the doctors who have taken out time for this webinar on tilted implantology with the R-line series, where all the implants are CIH and DSI, which have been used in the cases which I'm going to show in this presentation. I'll be just sharing, some important insights in the next 40-45 minutes, where I'll be sharing some of the important cases, how we are using these implants in different situations. So without wasting any further time, let's start with the presentation. So the first question is that where do we actually use tilted implantology? Tilted implantology is basically used in cases where you have atrophic jaws. That is, either the maxilla or the mandible or some segment of the jaw is atrophic, where we can't do conventional implants, or we require bone grafting, or we are compelled to do, delayed loading. So how do we do it? We actually use these CIH implants, which are tall and tilted. They are conical in shape. And in conjunction, we also use DSI implants, which are your regular normal Israeli implants, but they are used to solve these cases with easily. And how do we do it? We use certain surgical protocols in order to achieve higher primary stability of the implants, so as we can achieve higher torque value, so that we can load them as soon as possible. And of course, these things offer distinct biomechanical advantages and prosthetic advantages. We can load the implants immediately or early, and the results are, both functionally and aesthetic outcomes. They are both satisfactory and predictable. So in addition, clinical studies have demonstrated that by tilting the implants distally, there is a reduction of cantilever of about 6.5 mm in the mandible and around 9.3 mm in the maxilla. So we know that cantilevers are not good for the longevity of the implants, and therefore these tilting of implants help us in avoiding the cantilever. So they offer better load distribution, and the implant support, since it is moved posteriorly, it also allows longer implant placement, and therefore greater amount of bone to implant contact, and hence greater amount of implant stability. So there are several studies in the literature, but this study by Michael S. Block in 2009, it says that based on the a review of the several studies, it says that the survival rate of implant is perhaps lower in case of grafted maxilla when you compare it to non-grafted maxilla. So they did this study where they checked the clinical outcome in about 64 grafted maxilla versus 180 non-grafted ones, and they found that the statistically significant lower cumulative survival rate was there in case of graft group, which was only 75%, and in case of non-graft group, it was 84%. So, studies, these many studies are there in the literature which replicate this kind of final conclusion. So let us just, before we actually proceed further, we should know that what is the basic philosophy of tilted approach. So I believe that, in the tilted approach, there are 4 things that one should understand in order to master this technique. First is your bone. Second is your implant. And third is the type of abutment which you are using. And finally, the processes. So in this technique, we are basically using the native bone, using a graftless approach. We are not using block grafts or extensive surgeries, or to opening the flaps too much. So this is like a minimal invasive technique, and we are strategically placing the implants in certain areas which are important from biomechanical point of view, which are favorable. And through the cortical stabilization in the region of pterygoid, nasal, or sometimes zygomatic, we are able to load the implants very soon. And The type of implants that are used here, they are of grade 23 type, they are type 5, and the diameter and length allow us to solve any case. Perhaps 99.9% cases are possible. We can solve it with DSI and CIH implants. So our workhorse is 3.7 diameter implant, or 3.75 or 4.2 millimeter diameter implant. Along with that, in the multi-units, we are correcting when we are placing the implants in tilted fashion, we can correct the angle by using a multi-unit abutment. And finally, with the help of this cross-arch stabilization, that is from one side to other side, we are able to utilize and provide greater stability to our processes. And of course, we should have some knowledge about the type of processes. In certain cases, when we find that the implant torque values are not too much, or we need some, in that case, we provide a soft load using a acrylic or a composite processes over a metal framework. Otherwise, normally what we give is a metal framework, a DMLS framework layered by ceramic. And of course, it gives ample time for loading, because these days we are also using digital protocols. So currently, I am able to restore full mouth atrophic cases with 6 implants in the maxilla, 6 implants in the lower, within a span of 5 to 7 days comfortably. So if you see the force dissipation zones in the craniofacial skeleton, there are 3 main zones that one should know about. Because whatever food we eat, whatever the patient is going to eat, the forces are going to be dissipated in 3 trajectories. So these trajectories are marked in 3 colors over here. The first trajectory, as you can see, this is the green trajectory. That is the force they travel through the nasomaxillary buttress. The second is your red one. The second is the red one, through which your zygomatico buttress region, where from the premolar or the molar region the forces travel. And at the back, you have this yellow region, which is your pterygomaxillary buttress region. So in this tilted implantology, we normally use at least 2 of the cortical anchorages in order to provide greater anchorage to our implants. So the available cortical anchorage in maxilla are basically your nasal floor, nasal spine, palatal bone, pterygoid plate, zygomatic arch, and of course we use the bicortical anchorage. And when I say zygomatic implants, see, there are cases where which are too atrophic. I will tell you when we have to do zygoma, but there are many instances we can simply avoid zygoma also. So I will share that knowledge also. So this is a typical example of a OPG where we place implants and engage the nasal cortical and the pterygoid implant at the back, as been shown here. And in the mandible, whenever you have an atrophic ridge case like this, so 4 implants in a tilted fashion as shown here, they allow greater AP spread in the intraforaminal region. And if you are expert enough to handle the nerve bypass, then you can do that using a buccal nerve bypass or a lingual nerve bypass. So for compressive implants, buccal nerve bypass is a favorable thing that allows you to get more amount of DIC. So we do that in case of the region of second molar in the mandible. So, but even if some doctors are not comfortable with nerve bypass, still 4 implants in the lower, as shown here in the picture, are enough to load the mandibular processes. So before I actually start with the cases and give you some treatment planning, how we actually do that, we should have just some, this is especially for the beginners or people who are reluctant to do pterygoid implant. Let me just quickly share my views on it. That when I started off with, I was doing implants, did basal implantology also. I was doing sinus lift, but pterygoid implant was, I was scared of it to do. So I read a lot of literature, went through a lot of videos on the internet, took some, training from India and abroad. And finally, what I found that pterygoid implant is such a wonderful implant, which is like a game changer. It immediately provides you so much high torque value that allows you to load the entire arch immediately. So over here, if you see, just one thing, I will request all participants to kindly mute yourself so that I can concentrate over here. Thank you so much. So over here, we have this first picture. As you can see the top left picture over here. In the top left picture, hello. I hope I am audible. Am I audible?
Yes, sir. Yes, sir. Please continue, sir.
Yeah.
Audible,
Thank
very
you,
much. Very, very good.
Thank you, sir. So in the top left picture, you find that this is the sagittal view of the the maxilla of the posterior maxilla. This is part is basically the pink portion is showing the maxillary tuberosity. The black portion is your sinus, and just at the back you have this pterygopalatine fossa. Okay, this tear shape, this teardrop shape. And as you just go down, this bone is actually your pterygoid bone. And in between the pterygoid and these, you can see these are two plates. One plate is this, the other plate is this. These are your medial pterygoid plate and lateral pterygoid plate. And in between the medial pterygoid plate and the lateral pterygoid plate, you have the pterygoid apophysis, which is your exit point, which is the high dense bone area. So let's understand it better through another picture. If you see another picture, which is down the lower left picture, this one. So here this is again a sagittal view where you see that you have this, if you want to engage the pterygoid bone, you will have to start on third molar region or the second molar distal region, and you will go in and you have to follow an inclination in a tilted fashion. That is, this implant is basically having two types of inclination. One is your anteroposterior inclination as being shown here, this way. So this is one inclination. This is roughly around 45 to 75 degrees. So I don't like to mention the degrees because each case is different, anatomy is different. So we'll discuss how we actually judge that also. So if you see the another picture over here, this is a coronal picture, the top right one. This is a coronal picture where you find these two plates. This is one plate, this is the second plate. Oral means this is the palatal side. So this becomes your medial pterygoid plate and this is your lateral pterygoid plate and this is your maxillary tuberosity. So you take a suitable starting point from the maxillary tuberosity, and then you aim towards the medial side. But you have to aim towards this particular part is called the pterygoid apophysis. And in between this pterygoid apophysis and maxillary tuberosity, you have the pyramidal process of the palatine bone. So these implants are also sometimes known as the pyramidal implants. Now, this pyramidal bone is highly dense. So over here in the lower right region, you find this dense portion. This is of high density. As you move backward from the maxillary tuberosity, just a few millimeters away, you find this highly dense bone. This bone. So this is a highly dense bone. This is white in color. Now this bone is so dense, so it offers around 7 to 8 millimeter to our implants. And when you engage it, you suddenly get very high torque value. So when you are placing pterygoid implant, and if you are not getting high torque value, this means that you are not hitting the right spot. So over here, before we move, further about the surgical, little bit on surgery, just see that this is another picture which is showing us, this is the medial pterygoid plate, lateral pterygoid plate, this is the sinus. And what you see in the blue portion, this blue portion is your pterygoid fossa. This is an empty space. If you go into it, there is no problem. So few millimeter into the space is not an issue. Okay. And if you see the lower left picture over here, this is again a coronal view. So we are going from the buccal towards the palatal, but not too palatal also, because if you go too much palatal, you have this palatal artery. This palatal artery is not to be disturbed. Okay. But if you go buccal, if you start from the maxillary tuberosity, slightly buccal to the maxillary tuberosity, and you don't go medial and you go lateral. So here the problem arises. First thing is that you'll not get torque. And if you go a little bit superior to this part, this is your medial, this is the hemular process of the medial pterygoid plate. As you go superior and lateral, you have these blood artery, and which is your third branch of the maxillary artery and pterygoid venous plexus. So this is not the area which we would like to go. But if you follow the inclination which I've just mentioned in the previous slide also, that you have to go from the buccal to palatal, and you have to go upward and upward, inward and backward. So this is like your, just like what you do for the PSA nerve block in the soft tissue. Here for the pterygoid bone, you also go upward, inward, backward. But the question is that how much inward? Inward means buccal to palatal. So when we go buccal to palatal, we have to go, just follow my cursor. You have to go from buccal towards the palatal side in such a way that you are just lateral to the pterygoid humulus. So this is your hemular process of your pterygoid bone. So you have to be just lateral to this, and you have to go superior to this. Okay. So this picture on the lower right region that you see, This is a typical example of placement of pterygoid implant. It don't mind you that this implant has to be reach a such a level that it is below the lower border of this tear shape, tear आंसू के shape का जो ये this you shape that you see on the X-ray, you have to be below this. Okay, because at this region, if you from the lower part of the maxilla till this part, it is around 22 millimeter. Okay, and we are going in a tilted fashion. So even if you are placing 22 millimeter implant, 23, 24 millimeter implant, you are way away from the arteries. So you are in the safe zone. And one more thing is that if you don't follow this direction properly, or if you apply too much force, and by by when I say you're not getting torque and you're still trying to place implant, or you're exerting too much force while placing an implant, then it can lead to complication. But this one of the complication which is rare, but it is there in the literature, is that the implant get lost in the infratemporal fossa, as you can see in the top right picture. But if you follow the surgical protocol nicely, then 99.9% times you will not face any difficulty. So this is one other picture. To the top left picture, this is just a clock position to let you know that we are starting from nearly second and third molar region. You go from the buccal, reach the palatal, and but still this is a pterygoid humulus. You are slightly lateral to it. Okay. Over here, if you see the lower right picture, there are two angles which are given in the literature. If you start from the second molar, then you will have an inclination of around 45 to 55 degree. Okay. But if you start from the third molar region over here, then the angle is going to be roughly around 70-75 degrees. Okay, so that way you can reach the pterygoid apophysis nicely. So this is the top right picture. If you see, this is starting from the maxillary, it is engaging towards the pterygoid humulus, and it is few millimeter of the implant. It is inside the pterygoid apophysis, which is a hollow area. It's not a problem at all. If you go beyond the pterygoid apophysis, you have to go beyond the pterygoid apophysis and be 2 or 3 millimeter into that hollow space. It's not an issue. So before I move further, I would just like to read out your comments, that if you're understanding or if you have any doubts, so that I can you can type it in the WhatsApp group. If you would like to some questions or anything, you have some concerns, or if I'm good to go, just please type yes, I can yes, you can proceed, so that I can move further. You can type it in the WhatsApp group.
Sumit sir, right now,
Yes, sir.
the Zoom, people are really loving it. We are around 100
Yes, sir.
participants. Many are not able to
Thank you,
enter.
sir.
And even I'm
Yes,
seeing
sir.
the Facebook link is, already there are 100 more around. So 200
Okay,
people
sir.
are listening to you, and there will be group of people who are relatively new. So
Okay,
just
sir.
a small request on behalf of
Yes, yes,
everyone,
sir.
if you could just
Yes.
sometimes just slow down a bit,
Yeah.
so that
Okay, sir.
especially for the newcomers. Otherwise, what knowledge you are sharing, trust me, I
Yes, sir.
can tell you, I took years to get it, which these people are getting in 15 minutes. I
Yes, sir.
am sure people who are understanding
Yes, sir.
and can
Yes, sir.
acknowledge the amount of information you're sharing, sir. Thank you so much, sir.
Yes. So, okay, thank you, sir, for the adulation. Now, the next, I proceed with the nasopalatine implant. Now, this particular implant, again, I was very uncomfortable, because many times I used to read in the Facebook cases and on the literature that this is one area which one should use. But I was confused that what is nasopalatine area, because I'm a prosthodontist, I'm a professor in prosthodontics, and I read that you should rather relieve this area, otherwise there will be numbness and all that. But I went through the literature, got myself educated on this, and I found that even if you remove the contents of this nasopalatine area and you place an implant in this area, this can offer good anchorage to our implant, and clinically there is no problem at all. And even if in majority of the cases, rather 99% cases, you will not get any numbness. Even in the last 1%, if at all patient feels a bit, it is only a transient phase. Maybe in few days it will be normal. So nasopalatine implant is basically an implant which is helpful and can bail you out in certain situations. So let us just see the sagittal section over here. If you see, take up a sagittal section in between the central incisor. If you see, this is your nasopalatine region. Okay, so this is your buccal side, this is the palatal side, and in between you have this nasopalatine forum and the canal. Now this canal, it is not as what you see over here. It's not same in all cases. In certain cases, for example, over here, if you see the topmost right portion over here, the nasopalatal canal, it is cylindrical in shape. In the lower left, in certain cases, you will find that it is hourglass shaped. In certain cases, it is banana shaped. So in every case, you have to evaluate on the CBCT that how we are going to engage it. Okay, of course, expert people who are more experienced, they did not do CBCT. But for beginners, I will suggest that you take a CBCT and check where the canal is, and accordingly, you can engage this area. So this is one picture to show you that if you have this, the canal moving from the, it is going palatal in this way. So you can put an implant from the palatal towards the labial like this, and then you can correct the angle using a multi-unit. Over here, if you see the second picture, if you have, a resorbed ridge case like this, need not do any ridge plate or do bone grafting and all that. What you can do, you can simply put if the canal is slightly parietal, you can start parietal and place it a bit deeper like this, and you can engage it. So these, according to the position of the canal, you are going to engage it, because this canal varies in position. It can vary in, in shape. So you have to know where your canal is, and accordingly you will do the drilling. So what we do exactly, we normally, what we do is, when we open the flap, we reach out to this area, we use a 15C blade, and we surgically expose this, nasopalatal foramen region. We take out with the help of blade, we take a, some instrument to take out the content, we cut it out, and then we take a round rotary surgical burr to remove the entire contents of the soft tissue which is present in this canal, in this nasopalatal canal. And then we do we follow the drilling protocol, and then a suitable size of the implant can be placed. Just like in this case, we have, a DSI implant was used. Over here, another case is that when we are doing these kind of implants, many times we have to go and do a nasomaxillary implant, and therefore we should know that what is nasal bone anchored implant. So let me tell you that one is that when there are many areas which one can engage in the nasal bone only to get stability for our implant. One is the nasal floor. The second is the lateral part of the nose. The third is the nasomaxillary buttress region. And accordingly, and also in the center, you have the vomer bone also. So I will tell you each one as I will go further into the slides. So as you can see in the first picture over here, you can see I'm starting, the drill is being started from the premolar region, and it is going at the, almost lateral part of the bone into the, lateral to the nasal floor. It is penetrating, and then the final implant is being placed. So this is offering me good amount of AP spread. Over here, that we should also know that how to decide that if your anterior wall of sinus is, anteriorly coming, or beach mein sinus ki wall aa jati hai, and how to actually penetrate it. Should we place the rough surface implant, or should we only place, smooth surface implants? So I went through a lot of literature, and after, I gathered this information from reliable text, and I found that here, what if you are placing an implant in the premolar region and targeting the lateral nasal, lateral wall of the nose and in the nasal floor. So what you can do, you can start from the premolar region. You should know that what is the amount of residual bone in this area. So if you are drilling from the premolar and you are encountering the sinus, and then you are reaching the nasal bone, so in this fashion you can engage it, and you can also put a rough surface implant. But should this be done every time, or should some protocols are there? The protocol, I'm just sharing you the important point over here. There are, however, some other protocols also, but due to paucity of time, I cannot cover all the aspects, but I will cover you the most important aspect. The most important guideline is that over here, whenever you have around 3 millimeter or more of residual bone height in the premolar region, you can move in this direction and place safely. You can place a rough surface, CIH implant or a DSI implant, preferably CIH implant, it will be preferred in this case. And if the residual bone height is less than 3 millimeter, let's say 2 millimeter, then you have to deflect away this sinus membrane, or you have to open a window, and do some grafting over here and then place this implant. But if you really want to avoid zygomatic implant, so this is not a replacement for zygoma implant, but in many cases you can simply do this kind of thing and you can avoid the type of implant which you are not comfortable with. Okay, so this is this is where we reach to the treatment planning. That is how we plan the treatment for tilted implants in case of atrophic maxilla. So over here, if you see, there are several zones: zone 1, zone 2, and zone 3. So in the zone 1, this is basically zone 1, zone 2, zone 3 was given by Bedrosian. So there is a Bedrosian classification which says if you have less bone if you have only bone, if you have bone in all three zones, you do conventional implants. If you have only bone, if you got bone in only premaxilla and premolar, so you can do all on 4, or you can do all on 5 in the intrasinus region. But you can't give posterior, you have to give a cantilever processes. And so, or if you have got a good pterygoid bone is there, which is there in most over 90% cases, you will get good pterygoid bone. So you can give all on 6 processes there. But I just want to tell you that you need to evaluate the bone nicely so that before you plan yourself well. So how you actually going to plan, I'll just show you in the further slides. So this is the top left picture. If you see, I hope everyone can see, because in my presentation, mostly I have made this presentation with pictures only. Okay, I don't want to bore you with theory part. So just the practical aspects, I'm sharing it with you. So over here in the top left picture, if you see, you have, this is a typical example of a an implant, full mouth implant case that approach us. This is a typical picture. You always get pneumatized sinus cases. In more than 80% cases, you will find pneumatized sinuses are there. And you are compelled to do either sinus lift and all those things, which we don't do nowadays. I used to do it about 7-8 years back. Nowadays I don't do it. In these type of cases, the planning is that the simple planning is that in the maxilla you can put 4 implants with maximum AP spread, so which can allow which is allowed by the anatomy, that is the anterior wall of the sinus is to be noted. So if it is present in the in the premolar region, and if you can place a second premolar implant, you can give you can easily you can give what you call a molar as a cantilever, just like has been shown as an option 1 over here. This is option 1. So in option 1, you are comfortable, you can place 4 implants. If at all in the central incisor or lateral incisor region you don't have good bone, so what you can do, you can use the tilt approach and use this bone which is in the center. Now this central bone is actually your vomer bone. Normally we don't talk about this. Okay, so these are remote anchorage solutions. Okay, so these vomer bone, nasomaxillary implant, they bail you out in such situations. Okay, so even if you give a prosthesis of this sort where you don't want to do zygoma, or you are not comfortable with pterygoid, at least you can give some prosthesis to the patient and you can solve the case. But however, this option is not possible in all cases. So what do we do? Another option, I just told you, you can place this nasomaxillary implant, or if the residual bone height is good, you can 3 millimeter or more, you can give a nasomaxillary implant where it will traverse through the sinus. So this becomes your transsinus nasomaxillary implant. Or if the residual bone height is less than 3 millimeter, I just told you, you have to deflect away the sinus, open a window, put graft, and then do that. So this is another approach. Option 3 is that you put these 4 implants in the front as being shown here, and in the back you train yourself to do pterygoid implant as being shown here. So because pterygoid is something which entirely changes the game, because in the 4 implants, if you are getting a torque value of, let's say, 30 30 30, you are getting, let's say, value of in one implant you are getting 20, the other 3 are at 30, so you are still below 120. When you place a pterygoid implant, you get a certain rise in the torque value, because if you're engaging, if you really hit the spot, one pterygoid implant is good enough on either side. So that means that your composite torque value, that is a total torque value of the case, will suddenly jump above 120 easily. And the guideline is that if you are getting a composite torque value of more than 120 Newton, you can easily load that case immediately without any problem. So pterygoid implants is a must that everyone should learn to solve such kind of atrophic ridge cases. Otherwise, you will be compelled to do cantilevers, and cantilevers are not good. Like this, another option is that over here, if you don't get, if you're not able to place the vomer also, you don't want to do grafting also, the best way is that you place nasomaxillary implant, and in the center you can place a nasopalatine implant like this, and do pterygoids also. However, I don't like option number 4 too much, but but I will say this option really works as well, because it is mentioned in many literature, and I have done it personally also in many cases, and this actually bails you out without using zygoma. I'm not saying that you should not do zygoma. I will just show you option number 5. In option 5, when you find that nasomaxillary implant is also not possible, the maxillary bone is so too soft and cheesy, so in those kind of cases you have to use remote anchorage. And in such cases, what you do, you have to place, in addition to nasal implants and pterygoid implants, you have to put one zygoma implant like this. And sometimes, even if when your pterygoid is also not there, or if it is a resected case, you have to go for quad zygoma. So these are the different options, or the how you plan the treatment for tilted implants. So let me just I hope you all people are with me, and because I'm just trying to tell you things which with the way I see the cases, not from the book point of view or some particular literature or journal. I'm just sharing with you how I do the cases, how I make the treatment plan. So if you are okay with my my way of whatever I've explained, or you want me to repeat something, you can please ask me, or you can ask in the chat box, or in the WhatsApp group. You can just write, if you want to put some question or anything, I will answer, or I will, or maybe I can take up all the questions at the last. So just kindly let me know.
Sumit sir, we will
Yes, sir.
once again, I
Yeah.
want to thank you, because the way
Yes,
you
sir.
are simplifying everything, I'm
Yes, sir.
sure everyone is going to really enjoy the amount of information in such short time you're giving. So I can't,
Yes, sir.
I'm overwhelmed by the amount of information you're sharing, sir. I think all of us
Thank
should once again applaud Sumit sir, the way he's,
you, sir.
systematically making it so clear for you. No amount
Yes, sir.
of thank you would suffice, sir. Thank you so much. And I would just
Thank you.
request, so that the continuity is not lost,
Yes, sir.
you continue. I
Yes, sir.
am noting the
Yes, sir.
questions, sir, for you.
Yes, sir.
So
Okay.
definitely
Okay, sir.
there are some good questions which are coming up, but we don't want to
Yes, sir.
break the
Right.
information you're giving, sir. Please
Right,
continue.
right, sir.
Thank
So
you, sir.
I'll continue, sir. Thank you, sir. Thank you. So finally, what are the advantages of this particular type of approach? First is that it allows bicortical anchorage, that is high level anchorage is there. It eliminates posterior cantilever, which we really don't want from prosthetic point of view. It improves axial loading. Axial loading, tilted loading is always better than axial loading. Why I say that? Because about many years back, when I joined the first class on tilted implants, my mentor told me that जो हमारे आप देखो शादी ब्याह में जो टेंट लगते थे पहले, उसको जो टेंटिंग होती थी, उसके जो कील लगाए जाते थे, वो हमेशा टिल्ट करके लगाए जाते थे. इवन जो आप देखोगे स्टूल्स होते हैं, टेबल्स होते हैं, उनके जो लेग्स होती है, वो थोड़े से टिल्ट करके लगाए जाते हैं, so as to offer better stability. And of course, the final advantage is that we don't want to go for sinus augmentation and all these things, so you can easily bypass. Even patients don't want it. It's such a time consuming and a very technique sensitive procedure. So sinus augmentation right now, we are able to do cases without sinus augmentation in almost 95% of cases. So this is just one picture to show you how we actually do or place the implant. So over here, this is our lancet drill. We are placing slightly palatal, as Rohan sir has already shown so many videos on the palatal approach also. Recently also 2-3 days back, he has shown one video where he has done the palatal approach. So we do the lancet drill, and then we use the twist drill in the maxilla. And then normally we place 2 fingers on the buccal and palatal side if you don't want to open the flap, and then we can just place the implant. So over here, in this case, I have actually used some, this is your CIH implant, which I used I placed it by using, a compatible implant driver of some other Israeli company. And but the CIH implant got me, really high torque value. As you can see in the picture, the torque value is really high. Okay. And this is the pterygoid region, which I just told, it is upward, inward, backward. It is going this upward, inward, backward. But when you are placing this implant, again, I'm saying you have to go slowly, and suddenly you will find the torque value has increased to a, to an amazing value. Sometimes you get torque value of more than 70 also very easily. And then finally, you can place multi-unit abutment and you to straighten up and so as to get the prosthetic axis in favorable direction. So this is the typical picture of the the CIH implants or the from R line in action. You can see that 6 implants in the upper and 6 implants in the lower of the previous case. You can see that we are able to provide second molar to second molar restoration. We are able to achieve torque value of much greater than 120 Newton, and we are able to load these processes within the stipulated time of merely 7 days. And when I say 7 days, is in certain places where you don't get too good, lab services also. Let me tell you, even if you load them in 10, 12 days also, it is not an issue. You still, because the torque value, decreases after 10th, starts to decrease after 10th day, but it does not fall suddenly down to a level that you are going to lose the implant. So the 2-3 days here and there will not matter much. So I will start with another case. This is actually the case which a husband wife edentulous, they approached me, and their son actually requested me to do this case for them, and the patients had been wearing the complete denture, and they were unhappy, and they wanted something fixed, but they did not want to go too much invasive and all those things. And they have been advised to and they wanted second molar to second molar teeth also, and they wanted quick solution. They wanted something which is predictable also, and they also wanted, they had been told they had to consultation for everything, so they were aware about the screw retained restorations. So they wanted something which should be retrievable also. So based on that, I decided to use the CIH and the DSI implants, and I placed the 4 implants in the front, as being shown over here. So this is basically your nasomaxillary implant. These are the the nasal bicortical anchorage implant and the tuberopterygoid implant in the back. And I was able to get a torque value of more than 250 Newton. And in the mandible, obviously the bone is very hard, so you are easy to get good amount of bone. If you see, in this case, I have used, the CIH implant in this anterior mandible over here. And in the maxilla, I have used the DSI implant. So the unique part about this particular type of system is that you can mix and match also. You can mix and match both these type of implants. And in the lower left region, if you see, I have actually done a nerve bypass. So, just one small tip I'm sharing: whenever you do nerve bypass, please see to it that you don't give a nerve block, because when you are drilling, you are scared that we may encounter nerve. So whenever you do nerve bypass, try to do it in the 7th region and go from lingual to buccal. Okay, always go from lingual to buccal, from the center of the wrist towards the buccal side in the 7th region, and do it in the infiltration only. Don't do it in the when you are giving block, because in the block, if you are drilling near the nerve or you are approaching nerve, the patient will not give reaction. But in the infiltration, immediately patient will give you sensation of pain. Okay, and therefore you can redirect your drill, and you can easily place this kind of implant. And the drilling protocol of this particular type of implant has already been wonderfully shown in the videos by Rohan sir, which all of us have enjoyed already. And so I need not go into the drilling protocol, but this is just to mention that these implants are placed very quickly with minimal drilling. We are able to solve these cases very quickly. So over here, after the implants are placed, since right now our line, we don't have the scannable bodies, they are in the process of making. So I use the scanning bodies of some of compatible Israeli system, which are compatible to our hex of this particular implant, where we used these scan bodies as being shown over here. And after the scan bodies, they were hand tightened. The other prosthetic steps were followed. That is, the impression were made, the jig trial and everything was done, and the whole the designing of the processes was done. After the jaw relation was done properly, in the designing, we did all the planning where the teeth are going to come. And we also, before ordering the final processes, we first did a PMMA trial. So check out the picture on the left. This lady seems to be smiling very nicely. She was very happy, and this was done nearly in a span of 5 or 6 days. So she was very happy. So this is a PMMA trial where we can easily see the another tip is that whenever you are giving full mouth restorations, always, or you're going for expensive processes, do a PMA trial. Ask your lab to make a PMA trial for you. Then and when you do PMA trial, you are also able to judge the aesthetics, phonetics, the amount of the labial fullness, the amount of the freeway clear, the inter occlusal space, freeway space, Silverman's closest speaking space, all those things that you used to study in for complete denture, you can apply it here also. And over here, the final processes. This is a DMLS framework which has been layered by ceramic and by white and pink ceramic. The access hole, if you can fix those access holes with the help of Teflon tape and composite. And once that is done, all the occlusal adjustments were done. This is the frontal right view and left lateral view. And then this is the final processes with the on the implants has been shown over here. And the picture of the patient. You can see the fullness is achieved, the smile is restored, and a happy patient. Now, this is second case is our husband. Now, this patient was again, by looking at the result of the of his wife, he also wanted implants. But again, the same problem was there, that the sinus were pneumatized. And so therefore, what we decided that in this case, we wanted to go more minimally invasive. So what we did, and go faster also. So what we did, we decided to follow a digital protocol. So in the surgery, for that, what we did, we first made a denture, and in that denture, we put some radio opaque markers of composite. And then we asked the patient to go for CBCT. So this is the patient undergoing CBCT with the denture in mouth, as been shown here. And this blue thing that you see in between the upper denture and lower denture is the white registration wax which we used. And then after the CBCT, 2 CBCTs were done. One of the patient with the denture in mouth, and the second of the denture has been shown here, the dentures alone with the registration material. And then the planning was done. There are so many implant softwares which many labs in India support you with. So they give you all the planning. They use different softwares to actually they share with the screenshots of all the planning, and then you can approve them. So the lab shared with us this planning for implant placement in maxilla as well as mandible. You can see 4 implants in the front, 4 in the back. This is again the planning of the CBCT section, how they actually superimpose the pictures of the final, how the guide is going to come, and where from the hole, where the implant is going to travel. So you can see in the top left picture over here, this is again a coronal view from the maxillary tuberosity or the second molar region. It is traveling towards the pterygoid epiphysis. This is medial pterygoid plate, lateral pterygoid plate. In between, you have your pterygoid epiphysis. This is the sagittal section. It is going anteroposteriorly like this. Okay, this is your inferior fissure. Okay, and this thing is actually, this dark portion is actually your the pterygopalatine fossa, where we don't want to go. But where we want to go, just below it. This is the pterygoid epiphysis, and just before that, you encounter the pyramidal bone. So this particular direction, the AP, the anteroposterior inclination or the buccopalatal inclination was verified from us. We were happy with the planning. We went ahead, and then after that, the planning for the mandible was also done, being shown here. These are the surgical guides. Now, these surgical guides, they are made with certain type of 3D printed. They are really stable, and they are provided with stabilization pins. Now these CAD/CAM stands, they have got holes here. This is the metallic holes through which the drilling can be done easily. Okay, and then this is the picture showing the guides in place in the mouth. Over here from this hole, it offers you to allow a 2 millimeter twist drill to pass through them. Now this over here, the surgical guide is nicely placed on the pallet. You can see that this hole is there with this is cut in between. ये बीच में से ऐसे काटा हुआ है. क्यों काटा हुआ है? So that we can see the guide is fully seated on the ridge or not, because this is entirely flapless. So over here, when the guide was placed, it was stabilized using the 3 stabilization pins. So this is stabilization pin 1, this is 2, this is another pin, and all the holes are there through which all the 6 implants were placed. Similarly, for the lower one also, all the implants were placed, and only by using a single drill, we could just do the osteotomy and place the implant. So this is one example. Again, this driver actually I was having of some other Israeli company, so I placed the CIH implant. This is the compressive internal hex implant. You can see this is the all implants are the compressive internal hex implants, and this is offering good amount of AP spread with minimal invasive, flapless, very predictable. So sometimes we use digital protocol also, so as to allow us. We should never challenge ourselves that every time we would like to use without guide or with guide. We have to see the case and accordingly we should decide. This is, I mean, see, immediately after the surgery was done, you can see almost no bleeding is there. If the patient had no pain, we had given the patient antibiotic and analgesics for only 3 days, and that too also the patient didn't take. He told us later on that he did not feel like having. I was totally fine. And this is the final X-ray where we have the implants in situ. The multi units are being placed. You can see to correct the prosthetic axis, and even sometimes the lab only they also, when you are following digital protocol, when they provide the guide, they also tell you that which degree multi unit which you have to order. So that also information you have. So that's the advantage of following the guided protocol. After that, the healing apartments are placed as been shown here, and then we, at that time I did not have scan body, so I used open tray impressions as been shown over here. We did the open tray impression, did the jig trial and all those steps, jaw relation, everything we did. And this is the post operative frontal view. So this is when I see this picture, he's giving me a very a smile which is that shows that he is very happy, because he has also achieved the same smile which his wife got. So he was also very happy with that. And this is the a closer look. This is again DMLS framework, which is layered with pink and white ceramic has been shown over here. This is ceramic processes. The processes were delivered within 12 days. Again, this is the right view, the left view, and this is the final picture. And not to mention that we did all the relevant occlusal adjustments. This is now coming to case 3. Now in case 3, this is the mandible where you have the patient came to us for processes. So we simply made one denture. We duplicated in clear acrylic resin to allow us to. This is just a simple surgical stand that we made. We opened a flat flap and just do the pilot drilling with that. And then after that, what we did, we placed the DSI implants as being shown over here. And the tilt part is this premolar implant is that if I had placed it straight, I would have come in the canine region or maybe in the lateral incisor region. But tilting helped me to reach the second premolar region, which reduced the span between the last implant and this implant. So I was able to spread the implant in such a way that my supporting polygon became really good. Okay. So this is the second stage surgery. The healing abutments were placed, and the metal trial. Metal trial was again the hole was there, and this is the screw retained cemented processes. We at that time the budget of the patient was not great, so we didn't go for multi-unit. In this case, we had used angled abutment. On the angled abutment, we used this framework with the holes in it, and then after that, a screw retained ceramic processes was given. These holes were then finally they were filled with the Teflon tape and composite, and occlusal adjustments were done. And then coming to case 4. In case 4, just few more slides, then you will appreciate that how we are doing cases. So in this type of case 4, at that time I didn't know how to do pterygoid implant. So what I did, that I knew that I wanted to give a prosthesis till 7 also, but this you see this sinus was not allowing me, and I didn't want to do sinus lift also. So what I did, I just happened to give in the canine and the premolar region I could place straight implants. But for these molar implant, what I did, I went from palatal to from the palatal towards the nasal. So this is an example of your palatonasal implant. Palatonasal implant is something that seen in the lower right picture. You can see we have bypassed it. So instead of going into the sinus, or so as you can see in the top first picture, it is saying that I mean, for the beginners, it will look as if that the two implants are hitting one another. They are in common terminology, they seem to hug they seem to hug each other. ऐसा लग रहा है एक दूसरे टकरा रहे हैं, but they are in different planes. So what is it? This is the CBCT section. The lower right is the CBCT section to verify the palatonasal placement of the implant, and I could avoid pterygoid also in this case. So, at that time I didn't know pterygoid, so I had to place, implant in such fashion. So palatal laser is also useful, which we normally don't think. Then the processes was given, that has been shown over here. This is the final restoration. Then coming to case 5, again one patient came to me for the restorement of the third quadrant. Patient had gone early, few days back. If you see in the sixth region, I didn't, 6 and 7 were missing, and the sixth region, if you see the CBCT section, the bone was not present. So I could not dare to place an implant. If I had to, then I would have to do grafting and all those things. So what I did, I simply, tilt the implant from medial to a little bit laterally like this towards the distal side. And I was able to avoid this particular area. And then final processes, I was able to give immediate loading. And this is sorry, this was not the case over, I gave the ceramic, the acrylic processes immediately. And after 6 months, I gave the ceramic processes. So this is a picture of the metal ceramic rounds that were given after 6 months. And you can appreciate that all the the radiolucency has gone. Now coming to the case 6, this case, the anterior teeth, they had good prognosis, or I should say moderate prognosis, and the patient didn't want to go for extraction of any of the front teeth. And in earlier, I have seen cases of basal implants and also some conventional implant people also. So what they do, they tend to extract the healthy teeth also. That is not good. So what we do, we should always do sectional treatment if the anterior teeth are good. So what we did is, and we also didn't want to go for sinus lift. As you can see, this is the nucleotized sinus over here on the right and left side. So what we did, we actually did DSI implants in this premolar region, and at the back, one CIH implant as a tube in the tuberopterygoid region. Similarly, 3 implants on the right side. In the mandible, all 3 were DSI implants. So I could solve this case simply by giving a tuberopterygoid and using our CIH and DSI implants. This case was not a problem. The lower right is your final processes in place. So I don't think I need to explain you people about the drilling protocols, as we have already seen that in the videos by Rohan sir. So I can skip this. So I can just share this another information which you already know, that the compressive implant, they come in 3 diameter, 3.75 and 4.2. So 3.75 and 4.2, our workhorse is 3.75 most commonly used. They come in various lengths to help us and bless out in. They have got a straight abutment, 15 degree, 25 degree abutments, and multi units in various degrees to help us in different situations. And the best part about CIH and DSI implant, in my opinion, is which I think is that I'm able to solve many of the type of cases easily, which I was not able to solve. And the best part is that it is very economical, because in a country like ours, where cost is an important factor, patient don't wish to pay. The most of the patients who come to us, they don't have bone, and they have money, but those who have money, they don't have bones. But I get cases who don't have bone also, and who don't have money also. So I have to solve those cases in such a way where I have to use these tilted implants, basal implants, and also that too from CIH and DSI, because they offer very good economical offers. So that way I'm able to help those patients and make some money for myself as well. So this is the type of cases I wanted to share with you. And thank you so much everyone for patient listening, and I'm thankful to all Trisa Enterprises for providing me this platform to share my knowledge on this program. And I'm now open for discussion. And if you have any queries, and you're most welcome to ask me the queries. I will be happy to answer.
Great, sir. Great. Amazing, sir.
Yeah.
Thank Dr. You, Sumit, on behalf of everyone, I think even I'm amazed by the amount of information you shared in such a short time. I think all of us, we owe Dr. Sumit one big applause. And if you had to give one word for his presentation, you can just put up in the chat box, whatever one word which comes to your mind, because I haven't seen in a very long time such a crisp and informative presentation in such a short time. So let us all type MPTY once again. More power to you, MPTY, those for the newcomers who are not aware of this terminology. So MPTY to Sumit sir. Thank you, sir, for such an amazing
Thank you.
presentation once again. And I request
Thank you, sir.
once again all of you to type your one word which comes to your mind for Dr. Sumit sir's presentation in our inner circle WhatsApp group or in the chat box. So I'll just read some
Yes.
of the comments
Yeah.
till my team is
Yes.
compiling some questions for you.
Yes, sir. Yes, sir.
Dr. Shalu has written awesome presentation. Everyone is wishing you good luck.
Yes.
And I see a lot of amazing and positive feedback. Superb
Thank you, sir.
thing, sir. Really, sir, we are all overwhelmed by such simplicity of your presentation and how wonderfully you've done it. And I've also combined one to a few questions, sir, if you have time.
Yes, sir.
Okay.
Yes, sir. Of course,
So
sir.
one
Yes, please tell
one
me, sir.
question I would like to take up. In certain
Yes, sir.
cases, DSI implant being used instead of CIH, and moreover, after using DSI in groups which are segmental, it seems it can be loaded immediately. So what I think the doctor is asking is whether DSI can be loaded immediately and whether DSI and CIH implants can be mixed and used.
Yes, sir. Sir, you know better than me, but I'll just answer for the sake of answering that yes, DSI implants are can be loaded immediately if you have achieved a good torque value. In fact, any implant which has in which you are getting a torque value of above 40 Newton, and if you have done bicortical anchorage, so you will definitely get torque value of above 70 also. So yes, DSI can be immediately loaded. It depends on the condition, on the situation, what torque value you have got. Second thing is that if you are clubbing it with the CIH, yes, you can club it easily. There's no issue. There's no barring on that. You can club all your CIH and DSI implants either in maxilla mandible, whatever the case may be.
Great, sir. Thank you, sir. So now another one more question is that do you do immediate loading in CIH case?
Yes, sir. I am doing CIH for immediate loading only because CIH is like it has a sharp apex. It easily penetrates or even if it just engages the opposite cortical, I'm able to generate high amount of torque. This design is actually giving me osteo densification. It is like a Versa type effect. So I'm able to get high torque by simply just one drill. After one drilling, I can just switch to the CIH implants. So in maxilla, just one drill and you put the implant of 3.75 implant in a 2 millimeter osteotomy. The unique conical shape of this implant and the sharp apex, it goes into the osteotomy so well it generates high amount of torque. So you need not worry at all. You can load it immediately. That's not issue.
Superb, sir.
Yes, sir.
Sir, Dr. Harish is asked, sir, in
Yes, sir.
all-on-6 case, if
Yes,
the
sir.
patient returns with a mobile prosthesis, assuming one of the pterygoid implant has failed, how do you manage it?
Sir, of course, whenever there are many things into it that if that pterygoid implant has failed and the patient is having pain and all those things. So first thing, if we are giving screw retain processes, so we will remove the processes and then we can remove that implant and quickly, if it is possible, we can place another implant. If at all we can't give the pterygoid implant, we would like and we want to wait for another let's say 2-3 months for the pterygoid apophysis to heal. But in that region, if we want to give time to the cortical to heal, in that case, we will wait for 2-3 months, and for that and till that time, we will section that particular side of processes from that side, and we will not load on that side. So that way, what we can do is we can give a processes which is divide of the pterygoid, but we will remove at least the second molar or the first molar, and we can keep the only the premolars in action on that side. And later on, if we are able to provide the pterygoid immediately, then we can perhaps do the another processes and load the implants easily.
Super, sir. Super. And one more thing I can add in this is, let's
Yes,
say
sir.
that,
Yes, sir.
Sumit sir, I request, can you just stop sharing your screen, sir, please?
Yeah, yes, yes. Stop sharing.
One more thing, what I
Yes,
could
sir.
suggest is, let's say you have placed 6 implants, and for some reason
Yes,
you feel that your pterygoid implant you're not having a very good torque. Then what you can do is you can load only your anterior 4 implants with 10 teeth, that is from premolar to premolar. Let your pterygoid implants integrate, and then you can in your permanent prosthesis connect all the implants. So that is another technique which you can follow. And I think we have got the perfect description of your presentation by Dr. Anurag. He says this one word for doctors. Sume's presentation is precise like a surgeon's blade. And this is, he also mentions that this is not a webinar, but a conference in itself. This is the value, sir, you have provided to all of us today, sir. Sir, hats off. And all those who are in Delhi NCR region, sir is available for consulting. So in case you are stuck up for any cases, I'm sure he will be happy to help. He's also one of our community members. And very soon he's going to get empaneled on the board of our line panelists and mentors. So that will make another official announcement sometime later. This is just within the inner circle group. I have unofficially announced it, but we also welcome you on board with this, with that also. And one more question, sir. Are you using DSI also for cortical perforation? Dr. Yogesh is asking. Sir, you are not audible.
Yes, sir. Am I audible now?
Yeah. Are you using DSI for cortical perforation?
Yes. I'm using, sir. I've shown cases where I've used perforated the opposite cortical with DSI only. So it's not a barring that you can't use DSI for cortical perforation. In fact, if you are comfortable, you should perforate it, and you can get greater amount of bicortical anchorage.
Perfect. Only thing what will happen, Dr. Yogesh, if we are doing something like what you just mentioned, okay, what will happen in the process is that if you have a situation like this, and this is a very, suppose, let's say you're doing a mandible, it is very easy to perforate the mandible and engage a conical tip rather than having a blunt tip implant and engage. So for this reason, the purpose is to make the things, very, very simple for all of us. But of course, sir is a very advanced user. He know what he's doing. But for beginners, I still recommend using CIH whenever you want to engage or perforate the cortical, and DSI whenever you want to do classical implantology. Now, there are lots and lots of more questions coming up.
Yes.
I think we'll take one or two more. This is a never ending topic. Yeah. Sir, is there anything else probably you feel, you missed out and you want to add, especially regarding the occlusion? Because Dr. Sridhar is asking, occlusion is lingualized till first molar question mark. That's his question.
See, in occlusion, let me just tell you that you have to, give one good contact on all teeth. The anterior teeth, you see, in occlusion, we must know that we have to use articulating papers. And articulating paper, when I say the anterior teeth, they are to be, you should be able to pass a 8 millimeter micron paper from the anterior teeth, but you should get good contact on your premolar, first molar, and as well as on the second molar. But the pterygoid implant is not to be loaded. Pterygoid implant, only I have seen only one or two extremely advanced users who say that they load pterygoid implant also, but in the literature I've seen cases where they never load. So I also don't try to do any heroism. I don't load pterygoid implant. I just put the teeth till second molar, and in many situations, if I find that if the patient is Bruxer or something, I will not. I will just don't occlude the second molar also. But you can easily load till first molar without a problem in all cases.
Perfect. Amazing. Even I think whatever you mentioned, I follow the almost similar protocol, sir.
Yes, sir.
Great, sir. Great. And Dr. Tiruvalam is asking, will there be trismus after placing pterygoid implants? If so, how long?
See, now this is again very important thing. Trismus, when it happens, trismus will only happen if you go and if you hit the muscles, okay, of the lateral pterygoid. And where are they attached? They are attached to the this thing, lateral pterygoid plate. So if you hit those muscles, you will get trismus for for few days, which may last to up to 1 month also. But with counseling and everything, but this only happens when you don't follow the directions, you don't plan it properly. तो जब भी आपको टेरिगॉइड इम्प्लांट डालना है तो आप कोई जल्दबाजी ना करो, आराम से डालो. अगर नहीं आपका माइंड कोऑर्डिनेशन नहीं बैठ रहा है तो आप रुक जाओ. But you must follow the x-rays properly, and also you have to use this finger. You should know where your pterygoid hamulus is. That process should be known to you. आप क्रिसमस बिल्कुल नहीं कर सकते अगर आप towards the apophysis or towards the medial side. But if you will go towards the lateral side, you will invite complications. So best thing is use your finger. The finger is actually your king. This is the CBCT. This will help you move in the right direction. So that way, if you this will allow you to avoid puncturing, damaging the muscle, the lateral pterygoid muscle, and that way you will not invite any trespass. But if at all it happens somehow, just simply remove the implant and allow the patient to settle down. Give the patient some medicine. In about few days to month, the mouth opening will also improve.
Perfect, perfect. Now I am getting also messages in my private inbox regarding
Yes, sir.
the economic part. So let me just
Yes, sir.
quickly inform all of you. So DSI implant and the CIH implant, both they cost 2,500 rupees. The abutment, whether it is a straight abutment or angulated, it costs 500 rupees, which means your DSI plus CIH will cost you around 3,000 rupees. Now, in most cases, what you could do is, especially if you are a beginner, you can place the implant, place the abutment, and later on you can do like a crown and bridge work where your crown will be not more than 500 rupees, which means your entire thing will cost you not more than 3,500 rupees. So that's regarding the economic part of it. Of course, if all of you want, then as a community bulk purchase, we will be working out something even much more definitive and much more economical for all. In case of complete edentulous cases where you want to use multi-unit, okay, wherein, for example, you are placing 6 implants, 4, 5, and 6, and you would require multi-units on top of it. Now, the implant with the multi-unit with the cylinder is costing roughly 5,000 rupees. This is implant with the multi-unit with the cylinder. Now, all of you will agree that there are a lot of companies where only the multi-unit itself costs 3,000 to 4,000 rupees. But here, whether you buy the DSI or CH, the implant with the multi-unit with the cylinder is costing 5,000 rupees. And if people are keen in the group, we will work out some bulk offer also, which means your entire case of 6 implants with the multi-unit will still not cost you more than 30,000 rupees. How many of you find this extremely economical, especially when you're thinking about cases? I just want to know, especially those who have done few cases, you can compare it with the other system. 6 into 5, 30,000, Sumit sir, for a full arch case, especially in the kind of practice you mentioned where people are struggling or patients are not very comfortable paying a lot. It's nothing actually. What I want to know the opinion of doctors who are around. How economical do you find this option where you can give 2-piece implants with option of keeping them for delayed loading and option of using multi-unit platform like sir rightly explained, one abutment per time concept, and then give any kind of prosthesis interim or permanent depending upon the situation? So how many of you find that this could also be one big USP? Dr. Chetan is saying keenly waiting for the offer. Yes, Dr. Chetan, if more people in this group are interested, because for any offer to culminate, we require some kind of a bulk. So if there are more doctors who are interested in the bulk during the webinar, you can just type bulk. So I can, plan out something and then put it up in the group also. So just type bulk if you are interested, and I will just speak to my team and we'll see what we can do, not only for the DSICH, but also for the kit. If people, when you're typing bulk, if you are looking at the kit also, please mention kit also, bulk with kit. If you're looking only at the implants, just type bulk. So I get some idea and I'll have to speak to Impact. So just for those of you who don't know, Impact is one of the companies in Israel. Okay. So we are looking at Impact company, who is a top-notch implant manufacturer in Israel. And we are getting the R-Line series manufactured for them as per our requirements. So based on my knowledge across so many years, the designs, the abutments, the modification of drills are getting made. And of course, to get in anything, we require some volumes to get anything made. So everything is more doctor friendly. Whatever, even the feedbacks I get, we try to incorporate them immediately. Even Dr. Sumit has shared some important feedbacks which will further enhance the value of this system. So if all of you want the kit also, please let me know regarding the kit, or I'm assuming otherwise it is more with the implants. So that part I will put up again. I need to rework with my team and get back to you. But right now, if there are any more questions for Sumit sir, I think we can take one last one.
Yes, sir.
And
Yes,
trouble
sir.
him for one last time. But he's of course a community member and very generous to help all of us
Yes, sir.
whenever needed. So just one last question we can take up
Yes, sir.
from Dr. Sumit. Yeah. Sir, one question from my
Yes, sir.
end, just for from everyone's sake, if
Yes.
how do you identify, especially in the mouth, if you're not using a guide and doing flapless, how do you identify the position of sinus or the mantle foramen? I mean, you clearly explained the division of the zones
Yeah,
on the
yes, sir.
X-ray, but how to find it in the mouth?
Sir, it is simple as that you can you can use your RVG. I mean, just in the maxilla, if you could take some drill and you just place it on the soft tissue, take a X-ray or RVG, you will come to know where is the anterior wall of the sinus and where is the level. You can you take 2-3 RVGs and with that only you come to know. You can exactly precise.
Perfect,
It's not a
perfect.
problem.
Perfect, sir. Perfect. Excellent. Right. So, Dr. Yogesh, I think you once again I have to thank you on behalf of everyone for this amazing presentation. And doctors, please be generous. Dr. Sumit is a very busy practitioner, but on my request, immediately he agreed to share his knowledge in our inner circle community. We wish you more success ahead, sir. And all of you,
Thank you,
please
sir.
be generous with
Thank
your
you, sir.
praises for Dr. Sumit, sir. Nicely, sir, you have compiled everything for us, sir.
Thank
Your
you so
parting
much, sir.
notes, sir. Your parting notes.
So my parting notes are that I'm very, thankful
Especially for the
to,
beginners, how should they
yeah,
start off? I think
yeah,
I think you would
yeah,
probably recommend doing
yeah,
some simple cases
yes,
and delayed loading. So just how
yes,
the
yes.
beginners, yeah.
See, beginners, I will suggest them to, start with simple cases, as sir rightly mentioned. You can start with premolar cases or take up, first molar cases in lower first molar or, premolar area cases. Don't take up the anterior portion cases or the, molar, the second molar cases in the back. I mean, first you try to do DSI implants, which is, a very good Israeli system where you can do the cases in such a way that understand the drilling protocol, how to hold the handpiece, how to check whether your drilling direction is correctly oriented or not, and you don't even how to how to actually open sometimes the flap, how to suture it back, or sometimes how to avoid that also. You can open a little bit and just see the bone and replace it. So for the beginners, I will say you read the books which are there are two books which are available from Rohan sir from TISA Enterprises. One is a surgical book, one is a prosthetic book. And the best part is that instead of going to 50 different sources, you just follow these two books. Apart from your basic dental knowledge, I'm telling you, every point is mentioned in the book. You can just follow the how to use these two different types of implants, and along with that, if you are comfortable, do the basal learning also. See, basal is something which is a little bit has got different concepts, but this system is comprising all under one roof. So I will say start with DSI, and then you move to CIH, and you also learn that how to use remote anchorage. And but one thing is, don't go for grafting and all those things. You can avoid that. Simply just save your energy.
True.
Yes, sir.
Perfect, sir. Perfect, sir. So thank you
Thank
so
you.
much once again on behalf of everyone. And I have
Thank you,
shared
sir.
the Facebook link. I think all of you can share your 3 key learnings in the Facebook link or share it in our inner circle group. Till next time, I would thank you once again, all of you, and thank you once again, Sumit sir,
Thank you,
on
sir.
behalf of everyone. Thank you, sir.
Thank you, sir. Same to you. Thank you. Thank you, sir.